of what we are. Here we have leaders in the field discuss trends in AI that is in combination with healthcare. So we want to bring together researchers from a variety of fields with clinicians and advocates to collaborate and interact to solve problems in cancer and healthcare that were thought to be unsolvable a decade ago before the broad use of AI. Roughly, our format is about 30 to 40-minute talk to leave lots of time for interactive QA. And you can send feedback to myself or Peter Sadowski, my co-partner in this in the IFI. The University of Hawaii Cancer Center is located in the Kaka'ako campus. We have a building right on the shore. We support students and researchers in developing and integrating AI into their research. You can go to our website to find out more. This is also brought to you by the Hawaii Data Science Institute, which is a separate institute that sponsors students and to be fellows in data science and incorporate that into their dissertation and master's programs. We have very generous speaker compensations of a beer stein with our logo on it. People seem to like that. It's very effective. We were going to offer $10,000, but people seem to like the beer stein better, so we stick with that.
I'll take a free trip too next time, but yeah, to Hawaii. But the beer stein will work. So,
so our paper of the month is a paper by Dr. Kaufmann, and it's called Large Language Models in Radiology, Fluctuating Performance and Decrease in Discordance Over Time. And we encourage you to look this up and read it. And it's my great pleasure to introduce Dr. Chris Kaufmann, physician, innovator, medical device entrepreneur, and diagnostic radiology resident at the Dell Medical School at UT Austin. He has a clinical focus in breast imaging and a multidisciplinary background spanning surgery, biomedical engineering, business, and has contributed to innovations in stent technologies, surgical robotics, and regenerative biomaterials. And he holds multiple patents and FDA clearances. He previously founded a company called IOTA Motion, a medtech startup that developed the world's first robotic system for cochlear implant insertion. His current research focuses on the performance and perception of large language models in radiology, and especially how they impact the trust and communication in AI-driven healthcare. So it's a pleasure to introduce you, Dr. Kaufmann, and I'll turn it over to you.
Yeah, thanks for having Dr. Shepard, Dr. Sadowski, and very honored for setting this all up. Really happy to be here and looking forward to the beer stein and also telling you guys more about kind of giving my perspective on highlighting some of the key clinical questions and challenges with LLMs and AI and radiology that potentially might kind of influence your perspective or potentially just impact your work. Just coming from a diverse, more clinical entrepreneurial background, you guys are the experts in the AI, but hopefully I can provide a little insights on a little different perspective. So, all right. Just the disclosures. Yeah, Dr. Shepard mentioned it's not relevant here, but this is something I think this AI attestation here is something that I started to adding to talks, and I think it's kind of relevant in this case because it really kind of frames where we're at and where we're thinking with AI, and it kind of highlights the need for more transparency in a lot of AI that we're seeing and throughout the field. So actually, kind of a funny story here is I basically. I got there was this opinion piece that ACR had sort of recommended or asked about, and I had one of the residents sent it to me. I kind of was just as a thought experiment, kind of put it in one of the GPT models and prompted it to talk about the ethics of AI and radiology. I sent it back to them and did some edits and stuff, and they were interested in it, and kind of went through this process of like I edited it, they edited it, and things. And I sort of told them it was AI generated, but toward the very end, after we had made a bunch of changes, honestly, it wasn't the AI, it was maybe the AI rough draft or that LLM rough draft, but we had made multiple rounds and teams of edits. It was kind of funny, and at the very end of it, I added this AI attestation to it, and their legal team sort of rejected the entire piece. And so I think it just kind of points out what we're seeing is we need really alignment across the board in healthcare in terms of where do we draw the lines? Like what's allowable? Where's the, acceptable division of labor, both in clinical practice, both on the patient side of things. Because if we don't have alignment, we're not going to, how much research we do, how good a performance our LLMs have or AI has, it's not going to get ultimately to the patients or to the physicians who can improve care. So, this whole talk, the paper was one piece of, I think, the overall story of, me growing up kind of in the age of LLMs and ChatGPT. I think, I was a resident. It was, March, GPT like 3.5 had come out in 2023, I think, and so I was just kind of curious, it was rapidly changing. I was learning, it was learning, and so I was using it. And we found it's, as we all know, they're very powerful, assistive resources. They're rapidly evolving, but as I was using it, the question of, is this accurate? Like everyone had at that time, and there were a lot of these, like Google was publishing things about how they're answering X-rays and performing on medical, benchmark testings, but that's not medicine. Medicine is very, at least in the US, is sort of specialized and subspecialized. There's very nuanced aspects of it. And so I really wanted to see how specifically two domain-specific radiology performed. And so I just kind of, did that. And the question was whether I could even use it or trust it in the context of, a resident in training. And so, like I said, they're passing medical tests. And so I did a quick sort of, honestly, it was just kind of a quick little study I did, just assessing the different performance of the various LOMs on these in-service training exams. And, I got accepted to RSNA, and, that year it's got a podium because, I think timing is everything with throughout. And, it was an interesting perspective of how are we doing and comparing it. And so, and really the question of all this is, it comes down to trust, I think. It got me thinking, what builds trust? What makes, a user really trust the system enough to rely on it for either medical treatment care, for their own personal individual like insights or knowledge. And so, preparing for this talk, I really kind of dove into that. This meta-analysis here kind of summarized some of the key aspects. And I think what I found was that we were only looking at one piece of the pie here, which is the expertise and the performance aspect, right? And so, yeah, we can have the best models, the best performance, but if it's not reliable, if they're not transparent, if you can't connect with patients through our AI interfaces or through, that empathetic connection, it's not going to be used ultimately. And so these are things that I think about when I'm thinking about AI right now and when I'm trying to do some studies on. The other key part is sort of this contextual cultural part that I'll talk about towards the end that we're kind of interested and excited about in terms of continuing to build that trust. And so this makes a nice, it's hard to take something and make a nice little graph like this, but if anybody can recognize where this is inspired from, you get bonus points. But this is, so basically, we have two triangles, conjoined triangles of trust is what I like to call them. Essentially, you have your reputation, reliability tied to expertise and performance, but what kind of connects them is the context and the cultural component, as well as. And so, if you're not familiar, this is from the popular Silicon Valley TV show, which is great. It really hits on the startups journey, I'll say, just having gone through myself. It's a great watch if you haven't, but it's kind of a satire, but this is everyone's favorite, our CEO, Jack Barker, who had the conjoined trial success. You got to watch it to understand, but I think it does help in this talk to frame the discussion. So thinking more about trust, like why do we trust radiologists? And I think if we can understand, this problem and understand it well, I think it helps us to understand the solutions will be sort of obvious. And so that's kind of what I'm hoping to walk through and talk through here. So, we have years of training. I think I've probably done 10 plus years of training and testing, probably 16,000 studies interpreted, right? We have multiple, let me get my highlighter here. We have training exams, in-service exams. You graduate, you're general, and then if you go to specialty, You do multi-specialty board exams. And then beyond that, I think, which is kind of ties into the talk of continuously monitoring and AIs and the evolution of the LLMs is, you have continuing education, you have these licensing agencies, you have to reaccredit, right? And so the question kind of became like, if we have to take these tests, then I think if we're going to use these in practice, these LLMs and these AI models need to be taking sort of similar benchmarking tests. But when I sort of dove into it, there wasn't anything out there that was specific to domains. We had a lot of MedQA, PubMed. You guys are all familiar with these. Tons of non-medical, benchmarking tests. Your Helm, your Open Compass, Chatbot Arena things. And so I looked at all those and said, well, why don't we have one for LLMs? And if we can develop one, maybe it could potentially lead to, increased trust in a similar way that, physicians have that certification, that background transparent training process. And so, yeah, I mean, if you compare AI or LLM specifically to training, you could argue, they have better training. They have billions of data points, 175 billion parameters, something like that for GPT. Um, why are we not trusting? Why are they not, I mean, you guys are AI experts, kind of those underlying things, but from a high level, what is the process? And I think where I was, this study that on the fluctuated performance of LLMs is really this initial certifying exam as well as the continuing education side of it. So I wanted to look at the continuing evolution of it, both the initial as well as how it changes over time, because healthcare changes, scientific knowledge changes. We need to be changing the monitoring process or the benchmarking steps to do that. So this first study that they think is the keynote for the talk highlights was basically looking just as top triangle was the expertise and performance aspect of it. And so this is kind of was in the paper, but the goal really was start to kind of explore honestly and potentially down the road develop some sort of subspecialty specific LLM benchmarking, in this case radiology. And so we needed a validated test set, which you all know it has to be sort of expert validated. One of the biggest things I think early on, and maybe is confounding results down the road, we'll get into is it accessible by some of these data mining online or through the internet? It has to sort of be either firewalled. And so at the time, these Dixit questions, they're sort of in training resident level type questions, were behind an ACR login firewall. So we use those and plug those into the different LLMs. We wanted to see how they perform initially, also over time, and how that changed. This was early on, from 2023 when they first came out. But yeah, so what we found is, the performance varies kind of what you kind of expected. I think GPT-4, which we kind of now well accepted as this is significantly different from 3.5 and performed better, but nothing else was really significant. And then on the trend side, GPT-4 trend decreased over time, and then I think Claude sort of increased. So it's kind of variable, but it's kind of what you would kind of expect. It just changes over time. And like I said, the goal of this was really to point out and assess how that changes and understand it to make sure it's not, not going from, 80 to 50 or 60. And we're sort of keeping track of these. So unfortunately, like originally I wanted to compare, like I was saying, compare it to human performance. We want these LLMs to perform similar to humans, but at this time, we don't know the score equivalent or percentage wise for some of these for this type of test, but that would be sort of the holy grail, having direct comparison of performance results that are either available or some of these like the AMA might potentially have on hand to compare directly. So we can say, and someone is using it, that they're just as well trained or do better than a physician. And so kind of looking at it further of why are they changing, we kind of subsegmented is this, we call it discordance or basically agreement changes. And so this is a chart of going from, the wrong answer to the right answer, right to wrong, and wrong to a different wrong answer, to maybe kind of understand or get some insights into what's happening. So, but basically it sort of showed that the answers changed from some right to wrong. They sort of decreased over time across all models, which kind of suggests that they are potentially improving. It gives us a little more insight rather than the gross overall score. It's there's not a direct relationship between the accuracy and the internal consistency over time. But that's what this was sort of trying to elucidate, is really isolating the internal consistency and separating from just the accuracy when we're looking at kind of some of the benchmarking and test metrics. So I just, yeah. So, and then across subspecialties, this again from a high level is kind of how I like to think of things. Is this kind of points out that we really need, I think, there's variations across models within the specialties. It, could have been a factor of, question selection or sample size, but I think it also suggests that potentially we need sort of specialty or subspecialty specific, even within specialties such as radiology. There's, you can be a neuroradiologist, you can be an MSK radiologist. Even beyond that, it's another level of understanding and inferences and things. But it suggests we could potentially down the road optimize performance with really specialized models, and that kind of has implications in some of these subspecialty groups, so, like the academies, where should they be down the road kind of assessing these models and their performance. So yeah, I mean, you sort of saw, but we know they're performing at resident level accuracy. I think back to the triangle and the context of things, you want to kind of look at the intended use. And in this case, I think it's acceptable to use for, reference as a radiologist in training, not an expert level by any means, but that's the context. So changing context really changes your performance goal metrics. And I think in this case, if we make the context and the tests themselves were targeted for radiologists in training, I think, exceeding 70% performance is probably above average, I would guess, of what the actual residents perform. But it would be very interesting to see what the actual percent correct is on those individual tests. Let's see. Yeah, and then just I think continuing monitoring these over time, we saw that it's changing. It's the accuracy it's variable, but overall, it's just important to have this metric and understand it, so we have the transparency across the different domains. Just because everything's changing so rapidly in the field. And so this is just kind of thinking about it even more. So we were talking about the actual LLMs performing the test, but you could, ask the same question on the flip side, and this kind of stems from experience, with FDA and validating your actual measurement tool, making sure your ruler is, calibrated. This is essentially what I'm getting at, is we need to make sure we're calibrating our tests, and our tests themselves are continuously monitored and maintained. And so that means, having human experts continuously updating that ground truth, updating those test questions as they go, rather than using a 1 or 2 or 5-year-old sort of question set. If, say, there's new knowledge that comes out, it's updated. Yeah, and that helps to maintain the relevance, I think, of the test itself. So if you're using old data, you guys know this, old data, bad data in, bad data out kind of thing. And so want to make sure we're having the most accurate, most up-to-date test question sets. I think that's something that, at least outside of the medical field, I think it's hard to really have the transparency on some of the other benchmarking tests that are out there potentially. Because again, if we lose trust in the model or lose trust in the test, we need to be able to say that this is a validated and trustworthy measure of performance. Yeah, and then this is something that I've kind of hinted on already, but it's really, I think, up to us to decide who should be performing the test, who should be making the benchmarking tests and metrics down the ride, whether it's the industry and the company themselves. I think there are a couple private commercial entities that are starting to do this and collect some of the things that I'm talking about. Or would it be better to have academia or the scientific community sort of, I don't want to say control, but kind of manage some of these benchmarking test metrics. I think right now what we're seeing is at least the professional societies, I don't like RSNA or ACR. They're starting to, but I think it's going to take. They have the access to all of these test metrics. I think they're in a good position to potentially, step up and offer a controlled, kind of firewall test set of questions. That way, these they need to be essentially in a vault that can't be accessed digitally so that some of these future models won't, get corrupted or the tests. And that's kind of what this is getting at. And an interesting article that I found when I was sort of preparing for this talk is, this is out of Don, yeah, it's a preprint article, but basically he's looking at sort of the things I was just saying is finding ways to one, identify the data contamination itself, and then also developing in real time self-detection techniques for the contamination. Again, because if you lose trust, if the data is contaminated, if your benchmarking is, it'll sort of void and invalidate the whole process, the whole. And so he's identified ways to look at. You guys can take a look at the paper, but I think it's an interesting sort of step towards that direction of detecting benchmarking tests, validity, and errors, and also they've sort of developed some different techniques to mitigate the impact of the data contamination with some of these indexes that they're defining here. So, we talked about the expertise, performance, this upper triangle here, reputation, reliability of the test itself. I think this is the next phase that I'm interested in, that we're starting to look at, is really that empathy side of things. All of these components build to trust, that build to, add to acceptance of an AI technology in our daily use throughout our lives and in healthcare. It's specifically, we need to make sure that we're maintaining empathy, maintaining closeness, having those, touch points that people are familiar with a lot of our technologies and algorithms. So I think integrity and transparency, that's not something we're necessarily looking at, but I know you guys are, and Ariana is looking at as well with some of the explainable AI models. I think they're really interesting. And so starting to think about empathy in AI, because I think it's a critical and kind of a key component of acceptance of a model and the trust, building the trust. I started to think about ways, or look into whether, are there ways that we can measure empathy? Who's measuring empathy in AI? I think some of the, ChatGPT, obviously, if you prompt it, it can output very sort of empathetic and simulated responses. This is a controversial, can AI models perceive or express empathetic language that patients then comparing it to like a physician provider is kind of what I was thinking about this. So we started looking at that, and again, there wasn't really a great metric for empathy, for measuring or benchmarking empathy. And so I sort of just did some research and found there's different, models of empathy. I like this Morse theoretical model of empathy. It was basically based off of the motive aspects, moral, cognitive, behavioral. And so basically created a survey in this case, or benchmarking kind of question survey around that. And we inputted that into different, I think it was GPT 3 or 4 or 5 and 3.5. But essentially, we gave it an empathy score after a couple different prompts. We did a prompt with empathy, a prompt without empathy, and then assessed the comparison of the human rated. So we had 5 different, this is a very sort of pilot study, but 5 different medical specialists assessed the responses and score it based off of these different components of empathy and the benchmarking metric we had. And then just kind of similar to tying the internal consistency and the performance or accuracy, we wanted to kind of set up the design to where we're looking at a quality metric as well, because you could have a great empathetic, response. There's a trade-off, right? You could have a really empathetic response, but the quality and the completeness, all of these aspects are, terrible. Like it's not relevant at all and just complete gibberish, right? But if you only isolate the empathy score, you'll be missing a lot of the picture. And so that's how this real quick test was set up. Basically, we inputted these prompts. We kind of targeted the prompts to have empathetic outputs, and then one just kind of open-ended. In this case, it was for breast biopsies. This is one of the residents who was helping me out. But basically, we instructed it to explain to a patient who's about to undergo an image-guided breast biopsy procedure, all the things you would, as a physician or a doctor or nurse, explaining the informed consent process to them. We sort of prompted them to do that. And then we had various individuals scored in the survey responses. And it was basically 1 to 5, strongly agree, disagree, kind of set up for each of those metrics. And here's the totals. But basically what we saw, it's kind of what we expected, but I think, again, it's just to highlight some of these key points that we need to be thinking about is the empathetic prompted responses, scored higher in their total empathy score, compared to the non-empathy prompted responses. And interesting, maybe this is interesting, is there wasn't a difference in the quality aspect scores between a standard sort of open-ended response. And then we also prompted it, I guess I didn't show it in here, but we prompted it to utilizing the CMS sort of guideline standards for what should be included in an informed consent process. We included that in the training process. And compared that, and that's with this quality side. So we basically said, this is an ideal informed consent process, give us an output. And so that's what the quality score is. And so there wasn't a difference across both the human raters as well as the AI self-rated, which you can see on the left here. So this is AI rating itself, which, I think there's significance is still the same. It's probably not as large of a difference, but this suggests that, AI is potentially, these LLMs are potentially, at least GPT here, is pretty good at correlating with the human's assessment of it. And so we don't know. That's the problem with these, LLMs, some of these bigger LLMs like ChatGPT is we don't know, how they're validating any of their, outputs, what they're doing necessarily. It's all sort of a black box. And so that's what this test was trying to do, is trying to take a step in direction of understanding this better. And let's see. Oh, and another finding I didn't really say, we looked at the human sort of inter-agreement scores between the output responses of the LLMs. And it's the inter-agreement was poor for the quality scores, but it was actually pretty good for the empathy score. So it sort of suggests that, like, we're pretty good. We have sort of a uniform understanding of what it means to be empathetic. Whereas on the quality side or on a CMS, what should be included in an informed consent process is sort of highly variable potentially. Yeah, and so we hit on it here, but really just start to understand how patients are perceiving this interaction. So we first wanted to kind of, don't want to say validate, but at least do some early prelim pilot studies on our benchmarking metrics for empathy. And now we're sort of taking that and we're going to use those same surveys and that same sort of Moore's model of empathy benchmarking score that we said and tested with patients in a clinical setting, and sort of that real world setting that I think is really important for AI models and LLMs to really assess, because that's what really matters. In the lab, you have data that it could be skewed, it could be sort of biased, but in the real world is where you're going to figure out how you're performing, and you might have completely different results. So the next step is we have a IRB under review to basically have a LLM, the GPT-4 interactive LLM voice model, to basically give an informed consent to a patient as if a provider was giving it. We're going to instruct it to, say this patient's about to undergo a breast biopsy or a paracentesis, whatever the procedure is, provide informed consent and give them an opportunity to interact. And then use this empathy scoring system and benchmarking metrics to see how real patients are perceiving the AI itself. And we have other sort of survey questions, but I think this is a very patient-centered and human-centered approach that we, I take when sort of assessing different technologies across the board. So yeah, so that's sort of that bottom triangle that we're sort of looking at is, can the LLMs be empathetic? Does it improve sort of the patient's like comfort level? Lots of questions in terms of the patient experience that we're interested in asking. Yeah, and really in this case, it's more of a patient-facing LLM utilization rather than in the the provider side. A lot of things out there seem to the majority seem to focus on kind of the provider side and improving their workflow and things. But I think there's lots of opportunities on the patient education side to really enhance patients' experiences, their satisfaction of care that we can utilize. So that's the direction that this type of thinking and kind of studies are going towards. Yeah, this is kind of going back, but if you look at a lot of the data is, patients, and then specifically in the informed consent process, they really lack this sufficient understanding despite kind of what we're doing. So it shows an opportunity to improve it. And, LOMs are potentially a good solution in this case. One, because with increasing demands for healthcare providers and doctors and nurses, the times constraints are there, but also you want to make sure going into any of these patients understand their medical conditions or the procedure they're about to undergo. And some of the surveys that are out there and the review data is that, we're not doing a very good job here. And so hopefully with the LLMs, it can improve their comprehension and satisfaction, like I said. So I don't know if y'all played around with this. There's probably lots of models out there. Y'all might be even developing your own, but these interactive voice models, I think, are sort of the next progression of all of our text-based, all the flood of all the text-based analysis of LLMs. I think this is where we're wanting to go in terms of the voice, the true interactive kind of assistant type LLM models. And I think it's interesting. They're starting to think about some of these aspects because, you can choose how you want the voice interactive to be. You can, and it actually, just on our prelims sort of analysis, it really does potentially make a difference in patient perception of care and their understanding too. So, but these are some of the metrics. Yeah. So we want to, like I said, look at their satisfaction, look at the comprehension, and also the empathetic responses based on the patient surveys. And then we're going to compare that with a sort of observational study with a medical provider in the room to really get a baseline of their experience. And then I think, maybe Dr. Shepard, this is some of the things that you were looking at in terms of sort of avatar-based modeling is, this goes to that sort of fifth component of the cultural and contextual side of things is, I think the cultural and contextual component does sort of span that trust and helps to build that. And so, and in this case, it does how, an avatar, does someone's voice impact their understanding of uninformed consent or the information they're being provided or even their perception of empathy or all those other factors. How does that impact their trust in the AI model itself? And so you can have, in this case, Aladdin, everybody loves the favorite Disney movie, but one case he has the same line in both, but in this scenario, he's different appearance, different context, different socioeconomic presentation. And so does this change how we perceive AIs if we kind of change the face of the AI itself? And that's something that interested down the road potentially in going in that direction too, because I think that's where it's going with some of these AI avatars. Oh, here you go. So I think, overall, I sort of said here, but all of the components you need, because there's a trade-off. You can't, it's kind of a, all or none kind of thing. If you don't have empathy, you'll completely lose trust. If you don't have transparency, you'll completely lose it. It's a trade-off, but it has to be patient-centered. And so, I think there's opportunities and things that we're doing to really shape the nature of these benchmarking metrics for AI. I think we have a sort of a responsibility to do that, just both in the scientific and clinical setting, being the experts. And so I think this is just initial components that should be included. Obviously, it will evolve and change just like everything. But this is kind of the framework that I think is a nice benchmark potentially have. After I give my talk at RSNA, when some of 2023. I think there's interest. FDA is definitely looking at these things. There's interest in collaborating with them to help develop some of those things, some of the benchmarking metrics, and validation test sets as well. And again, I think we're in a position where we could potentially contribute to that, and provide our insights. So yeah, the FDA, I talked about it. I think at the forefront, I think potentially FDA has been looking at this for a long time, and there's been lots of sort of evolutionary changes since 2019 or so. There's been slowly releasing guidance documents because everything's so new and it's evolving so rapidly. They are thinking about the continuous improvement. They are thinking about all these things that I've talked about. We just need to make sure that we're in the conversations as well. And I think, should it be industry? I think it should be a combination of all these stakeholders who are potentially doing that. I think there are opportunities to give feedback to some of these metrics or some of these guidance documents that the FDA is presenting. But right now, I think some of these just public crowdsourced benchmarking boards are out available on the non-medical side. I think academic and scientific community, we could start to develop some of those similar kind of benchmarking metrics that are a little more monitored, I guess, and improved over time. So yeah, this is just to show that things are rapidly changing. It's kind of like a toddler growing up. We're moving quickly, and it's a fun time, but things can break. But as long as we're moving in the right direction and improving them. This is the latest draft document for AI-enabled software devices and function that we can provide input on to read. I would definitely encourage everyone to read all these guidance documents. There's lots of insights into them. A lot of people are thinking and talking about these, and it will impact the sort of the ultimate translation of your work. And so, starting from starting sort of from the end and the goal in mind of what they're going to need, I think helps to frame your future work and studies as well, because it's a lot of time and effort to do some of these developments and studies, but you want to make sure when you get to the end, if it's going to impact care, impact the community, and medicine, that they accept it as trustworthy, essentially, is what the FDA's agency of help us as a society, or as U.S. society, to trust that if it's proved that it should be safe and effective to use. So just closing here, I think, this coalescence of, I think, trust and technology is kind of key. I think with all these technologies, the goal and everything I think about is sort of enhancing our human basic capabilities. That's in the robotic space. That's how it's been very successful and presented. Essentially, the robotic systems can enhance the surgeon's, vision. It can enhance their dexterity. In case of automotion, it could enhance the controlled insertion kind of less than what a surgeon can do manually. But the AI diagnostics, these all need trust, but combined, I think it's going to be an interesting time for sure. But yeah, I think it kind of starts with that, but also kind of ends with trust. But like I said before, you need all the factors to succeed, which is why they're all kind of in a square, if you want, can join triangles there. So this is a small but mighty team. Like I said, we're the Del Med programs. I was one of the first in the class, but rapidly developing. University of Texas in Austin and Del Medical School have some world-renowned AI researchers that we're accessing and starting to build collaborations with. But also looking for collaborations and projects outside to continue to push the field forward. But yeah, Matul Gupta was the fluctuating performance was his. He led that work. Stephanie is leading some of the breast biopsy empathy, and Nisha will be sort of leading the patient sort of interactive perception study in the clinic-based setting. But yeah, I want to thank you guys for having me, and open up to any questions. Freezing. Can y'all hear me okay? I'm freezing. Oh, yep. This is my Austin collage, Texas collage here. See you.
Great. Well, thank you so much.